Well, clearly we have a lot of unmet need in type 1 diabetes. Many patients are not achieving the glycemic goal that we are proposing, putting them at risk of debilitating complications. We see that girls with a diabetes onset before age 10 have a loss of life of 17 years. Boys, it's even 14 years. So this is due to an increased cardiorenal mortality, and we have nothing good to offer despite all the advances that we have. So also the glycemic variability, the blood glucose swings are really troubling many patients. And if we would find a therapy that would reduce these blood glucose swings, that would of course be great. So sotagliflozin is a dual SGLT1 and SGLT2 inhibitor, who on the one hand inhibits locally the SGLT1 in the gut, thereby maybe blunting the postprandial rise of glucose, and also leads to the SGLT2 effect of getting all the filtered glucose out of the body, thereby reducing the glycemic variability, as we have seen in the clinical trials, also with other SGLT2 inhibitors. Reducing weight, because overweight is also a problem of many patients with type 1 diabetes because they have to eat extra carbohydrates because of hypoglycemia. We also see improved blood pressure if you have an elevated blood pressure, and of course an improvement of the A1C, which hopefully will translate into better long-term outcomes. So with every benefit, there's of course also risk, and one has to balance the benefit and the risk. I talked about the benefit. The risk is really an increased risk for urogenital mycotic infections. This in the studies had led very rarely to a discontinuation of treatment, indicating that is an easily manageable disease. DKA, of course, is a serious complication of diabetes treatment, and we know that these drugs increase the risk for DKA because they increase the ketone levels in blood. And so risk mitigation for DKA has to be in the center of selecting the right patients and educating the patients in an adequate way in order to have something in their hands that they don't develop DKA. Any patient who has a high glycemic variability and who's not meeting the goals would theoretically be an ideal patient. The European Regulatory Authority has said, because we have to balance the risk of DKA on the one hand, and we don't really know how the risk mitigation strategies that we are proposing, how successful they are, we should start in patients with a body mass index of above 27, so the obese patients with type 1 diabetes. These are the patients who are likely to have a higher cardiovascular risk, who would profit from the weight reduction, and very often they have a little bit higher insulin dose due to their obesity, which may prevent them to get diabetic ketoacidosis very, very easily. So this is the regulatory approval. Maybe in the long run, when we see that risk mitigation works, we will get another regulatory approval also for those below 27. I think in the center of the future research is now whether the healthcare professional education, the patient education programs, the high intensity that we are doing education for DKA, how to treat DKA, how to understand that SGLT treatment might lead to euglycemic DKA without an elevated glucose, whether all these measures are successful in making it really a very rare event that patients with the SGLT2 inhibition are actually experiencing DKA. I'm optimistic, but we need science for that.